Welcome to ASRS's Journal of Vitreoretinal Diseases Authors Forum. I'm your host, Dr. Timothy Murray, Editor-in-Chief of JVRD. On each episode of the JVRD Authors Forum, I will interview innovative retinal researchers on their studies featured only in JVRD and how these studies will impact our patients' care in our clinics. Tune in to hear directly from investigators about the clinical implications of the newest and highest quality research in the field of retina. Welcome to JVRD's Author Forum podcast. It's a pleasure to be joined by Dr. Stefanie Schuman, the Associate Professor of Ophthalmology at the Duke Eye Center, speaking to us about her manuscript, Diabetic Retinopathy Disease Burden in Patients with Lower Household Incomes versus Higher Household Incomes. Welcome, Dr. Schuman.
Thank you so much. It's great to be here with you. Thank you for highlighting this work.
Well, we know how important sort of the societal demographics are in our understanding for our practice. Can you take me through a little bit what drove you to look at this specific topic?
Sure. So we all know that diabetes is the leading cause of preventable blindness in the adult working population, and the prevalence is increasing. So poor glycemic control, systemic hypertension, and diabetes duration and lipid levels all are major risk factors for the development of diabetic retinopathy. There are also a lot of barriers to patients getting the appropriate care that they need. And so over time, I've seen a lot of these barriers affect patients. And this is one of the ways that we've looked at which barriers are affecting them and how can we improve and optimize the visual outcomes in these patients. So we're also thinking about the consequences of diabetic macular edema and vitreous hemorrhage in these patients that can lead to severe visual loss. And a lot of these patients need timely treatment and appropriate follow-up. And so we noticed that some patients initially present with a higher disease burden than others. And some patients don't follow up as we prescribe and then have worsened visual outcomes. And so we wanted to evaluate their treatment burden. So as I said before, there are many barriers in the care for diabetic retinopathy. And we're looking at a lot of these, but this one really can lead to severe visual loss. And so it's important to identify the root cause for some patients who either cannot control their diabetes or can't get to the office to get evaluated by an ophthalmologist.
You know, that's a phenomenal lead-in. Tell me a little bit about how you established the look for where patients fall in terms of household income, because there's so much devil in the detail of these studies to understand how you get to the final result.
So we're looking at the disease burden in the high income versus low income households and how that affects patients' diabetic retinopathy at presentation and their disease burden. And we evaluated many ways, and the way for our study for all the patients that presented to our eye center that made most sense was looking at zip codes. So we looked at the top quartile of high income versus the bottom quartile of low income households as far as zip codes.
And so you focused on zip codes as a marker for, for socioeconomic status financially.
Right.
We also know that there's been a big focus on distance from the care provider.
Exactly.
And it's looked interestingly lately, the distance from a care provider, that many of our lower income patients do have good access, but maybe there's more to the story than just having your retina specialist close to you.
Right. There are many different barriers to their care. Some of that is education. Some of that is, well, some people suppose it's the rural geography, but other studies have contradicted that. But all the various aspects of social determinants of health can affect how patients get to their care as well as how they control their diabetes.
I thought you did an excellent job putting the study together and how you elected to look at your data and the significance of the data. You know, this was one of those papers that I come in thinking that I don't have a bias, but I clearly do. And I think your paper fell right in line with what I would have thought we would find. So it's very supportive of what we've dealt with and maybe what many of us believe. What do you think we take from this to really help our patients in a day-to-day basis for our clinics?
Right, that's a great question. We really need to take the next step and ask patients after we see them and after we determine they need treatment and they need further follow-up. I ask them two questions. One is, will you have any trouble getting to your next visit? Because a lot of times we don't, patient, a lot of providers don't ask that. And sometimes you can be talking with a patient and they can tell you they may not be able to get to their next visit, but sometimes they don't share that information. And so a simple question can really be helpful to determine if you need to start that treatment the day of their visit or if they will be able to follow up. And the next question I would say is very important is there anything we can do to help you control your diabetes, especially if you know that their hemoglobin A1C is over 8 and if you suspect that they may not be doing everything they can or have some type of barrier, either if it's medication access or diabetes education or financial barriers or getting to the clinic and not having a car, all these different things can be contributors to patients having a worsened visual outcome. And so some simple questions can help alert the ophthalmologist to say, provide care or find out what the patient needs. And in a lot of cases, improvements are being made. There are some institutions that do have programs to help patients with all these different aspects that can help improve their diabetes control and subsequently their diabetic retinopathy. And there's also mobile screening. So we can get patients set up with a mobile screening location, and that can help. And there's also, studies like this. One of the reasons we did our study is to add to the literature and have us know what the current status is so that we can make governmental policy changes for patients like this.
I think that's important. One, I think you and I are both shocked by how few of our diabetic patients have a single screening exam. So
Right.
they never enter into the system. And I feel that's one structure and focus for us to move forward. That's definitely policy and maybe outside of ophthalmology itself. But then once they're in the system, I feel like we have a lot more opportunity to benefit these patients. One of the shortcomings for this, of course, is that there's such a variety of treatment approaches for these patients, and the costs are so variable. Some of the treatments that have the longest durability, where the patient may not need to see us as often, are, of course, the ones that are the most expensive. How do you put that into a thought process for you in taking care of your lower income patients?
I asked the patients about their ability to cover the cost if they have any hesitations, what they're thinking about the treatment, and definitely educate them on what is needed. And so, we work together as a team and decide what is the best treatment for them in order to optimize their visual outcome. Because the last thing you want is for a patient not to show up and then years later come in with fractional retinal detachments and very poor vision. So we really want to be able to discuss that ideally at the first visit to get that laid out so that the patient can share with the ophthalmologist their expectations and what is realistic for them.
So I think, dealing with their control of their hemoglobin A1C and their general health, such a low-hanging fruit for us to talk about, but so much out of our control as retina specialists. But the second choice is about what drugs we use and what's the frequency of evaluation. And then kind of this resurgence again of the thought toward laser surgery as a consolidation treatment in case our patients can't get back to us. It's very interesting to see that sort of swing of the pendulum, and I'm curious as to how you think that's going to move going forward.
Right. Well, a lot of that will depend on insurance companies and approval. And, these things change month to month sometimes. We try to offer the best treatment available. And at my institution, we have our financial counselor talk with the patient and let them know what's covered and what's not covered. And then we all decide together what is the best option for them long term, knowing their situation. So yes, you're right, there's a great opportunity here. We're lucky to have these amazing medications to offer intravitreally, and also the laser that has been shown to be beneficial for preventing vitreous hemorrhage and further proliferative changes over time.
Dr. Schuman, thank you so much for focusing on this critically important issue and really supporting potential for shifts in policy and reimbursement that may allow better equity in terms of our care provided. And I'd just like to thank you for putting the effort with your team into doing this for JVRD.
Thank you. Thank you for the opportunity, and hopefully this will help patients going forward.
Thanks for tuning in to the JVRD Authors Forum. You can watch and listen to more episodes on the ASRS YouTube channel and on popular podcast directories, including Apple Podcasts and Spotify. Visit www.asrs.org/JVRD Forum on the ASRS website to learn more. See you soon.